Thank you, chairpersons, for giving me this opportunity. So, whenever I get a call from my neurology colleague, they just whisper in my ear, just drain this fluid somewhere. May I have the slides, please? Yeah. So, whenever I deal with a disease which has multiple names, multiple treatment options, and multiple stakeholders, and nobody claiming that they are actually going to take care of this disease completely, I know that this is an open question. Open question as far as the natural history is concerned, etiology is concerned, and the treatment options are concerned. And then we discuss this disease with the patient in an environment of uncertainty, with my own biases and insecurities in their mind. So controversies, when and when not to do, there is no more a controversy for me, because whenever I get a call that you need to put a shunt, I mean you have already exhausted your all non-invasive methods and now you want me to put a shunt. When not to do, I am going to discuss it. Whether then the question happens whether you should go with an ONSF or shunt. Shunt then it should be a lumboperitoneal or a ventriculoperitoneal, valveless or the valve-based. If I have done the shunt and the patient has not responded, then to assess is the shunt is really functioning or not, is it over draining or under draining, and if the patient is still having the headache, then how to manage that one. So most of the times, once my neurology colleague asked me, and he discouraged me in asking too many questions about the patient, telling me that your role is not more than an item girl in this management of an IIH. Just put the shunt and go away. Do not ask further questions. That was the answer. But sometimes the movies get hit just because of an item song, and many a times the patient gets benefited just because of your shunt only. So this is a wonderful algorithm to put here when I am needed, once you have already exhausted, and then I need to put it in an acute setting or in a chronic way, so you should go with an ONSF or a shunt. A fulminant IIH, when the patient is at the brink of losing their vision in a very short duration of time, that's exactly the time I am needed. There are various options, like if you can't do a shunt at that time, do a lumbar puncture, but it has just a temporizing measure and the patient would get that same problem again. Gastric bypass, it's coming up, there is literature available, but it's not a treatment for the long-term vision loss. ONSD already been discussed. Shunts, then again, whether it should be a lumboperitoneal, ventriculoperitoneal, or it should be valve-based or the valveless ones. Acute indication, when there is an acute or severe vision loss at the time of initial presentation, and we do get the patients with such kind of presentation in our OPDs. Subacute, like the medically refractory ones, when the patients have persistently refractory headache and ongoing visual loss despite your all the measures. And this is the Birmingham protocol which they followed with this particular background of the Molan article, which was a very good consensus article published in JNNP. And then they did their own audit, and they found that the shunt failures among all the indications are maximum with the IIH and minimum with the NPH, and their revision rate in 1 month was 12%. That's a pretty high rate for a ventriculoperitoneal shunt, though it is in sync with the literature. Does opening lumbar pressure measurement helps in the decision making? Yes, it definitely helps. It's not only a temporizing measure, it's a diagnostic procedure for you to discuss whether it should be needed or not, but there is no single absolute cutoff value, and you can classify it into a mild, moderate, severe, and fulminant depending on the opening pressure in your case. When not to consider a lumbar pressure, lumbar drain or a lumbar shunt, and then absolute contraindication, just like any other, is a local infection. A relative contraindication, when you have a symptomatic or just an asymptomatic detection of syringomyelia or an ACM, because in those patients inadvertent CSF drainage may worsen their ACM or their syringomyelia. If you use a programmable shunt, then you can definitely mitigate this complication by graded drainage of your CSF and looking at the improvement. This would help both the ways of your pressure monitoring and the drainage. Lumboperitoneal shunt, a very fairly easy procedure. You all know, we put one end of the shunt into the thecal sac down, and that with a connector it is connected to the peritoneal cavity, and you divert your CSF from there. It's a technically simple procedure with a low complication rate, 80% effective in a short term. In the long term, it has a lower infection rate compared to the ventriculoperitoneal shunt, 1% in LP compared to the 7% in VP, but it has a higher failure rate requiring the repeated surgical revisions. And sadly, we do not have valve-based LP shunts in India. They are valve-less shunts in India. The second option is a ventriculoperitoneal shunt. We have programmable VP shunts which we put in these patients, but problem compared to the other indications where we put the shunts is that the ventricles are either chinked or they are smaller in size, and to hit them becomes relatively difficult. If you go with a traditional parietal burr hole, sometimes your shunt gets misplaced. Putting through a frontal burr hole, it ensures that probably you are going to be in the right place most of the times. So in patients of you can use the parietal burr hole if you have a neuronavigation, you have an intraoperative ultrasound, but at most of the places this is not available. So to be on a safer side, it's better to go with a frontal burr hole. If you look at the complications of shunts, it has its own set of complications which includes the shunt obstruction, catheter migration or dislocation, infections. This is the best in literature in neurology, but the shunt related infection is fairly common in our situation also. The valve malfunctions, and especially with the lumboperitoneal shunts, the complications of the radiculopathy and the abdominal pain, and they require the repeated shunt regions. That's a very robust literature. In this literature, Merkler et al., this is a 424 patients, it's a multi-institutional study with the predominantly ventriculoperitoneal shunt, and the revision rate is 39%. The rest of the studies, which are retrospective single center studies, they have a patient population of 20 to 50 with LP and the VP shunts, and they show that within a month the shunt revision rate is somewhere around 11%, and it reaches up to 60% till the time of their last follow-up. That's a pretty high number for a shunt. I personally like this study. This was one of my friends, Jaideep Thakur in US, and he compared the whole of the data available in the US for the VP shunt and the LP for the nearly 4,500 patients of the IIH. And there were 2,500 patients with the VP shunt, 1,800 patients with the LP shunt, and the revisions, removal, all these was much higher in an LP shunt compared to the VP shunt, so much so that they concluded that the presented results appear to call into question the selection of LP shunt placement as the primary procedure for the IIH, as this procedure is associated with a significantly greater likelihood of need for the shunt revision, increased length of the hospital stay, and the greater overall charges to the healthcare system. So it's a burden. So the question is still open because we do not have any comparative randomized control study with an LP versus the VP shunt to show which one is a better shunt. VP shunts are technically difficult in IIH, and if you are not that much experienced, just switch over to the LP shunt for some time, gain your experience with the VP shunt. And in India, if you do not have the neuronavigation at multiple places, then doing an LP shunt is a fairly acceptable, reasonable procedure which would take care of the patient's symptomatology. So once I have done the shunt, now what? Because the shunt may overdrain, the shunt may underdrain, and if you look at the patient's perspective, because that's the important thing we actually are looking at, the patient's perspective on the burden of the IIH, most of the times putting a shunt is going to take care of the visual problems, but the headache is one thing which may or may not respond to your CSF diversion. And in those cases, the question happens, what to do with this headache? So you should look for the shunt failure or the overdrainage, whether it has migrated or it has broken in its. You may need to revise the shunt. You can do a shuntogram. If the patient gets a relief in the headache in the lying down position, probably your patient is suffering with an overdrainage and you need to put a valve there. You should look for the papilledema again. If it doesn't, then you can do an LP and look at the CSF pressure again, whether your shunt is working or not. This is an article based on experience of 800 LP shunts done by a PGI alumni who happens to be the president of NSI now. So they evaluated and they concluded that if you put the shunt in the thecal sac to a shorter length, 7 to 10 centimeter, then your chances of the over drainage are reduced, because the CSF does not egress just from the shunt tube, it goes along the shunt tract also. So if you put it for a shorter length, your chances of getting an over drainage complication are going to be the less one. So just for the residents, it has 4 markings. Put your shunt up to the in between the second and the third marking, and this problem wouldn't happen. Still, if it happens, then put a programmable shunt. Persistent headache, your patient didn't get any relief, now it becomes a headache to you and the patient both. Look to, if you have put the shunt, you have already taken care of the ICP, but still if it is having, look at the typical migrainous pattern, and probably you now have multiple CGMP drugs, monoclonal antibodies and all those which have given good results for the headache control. You may try in those patients. There is role of anti-gravity and the adjustable shunts, but there is no robust long-term comparative literature. Whatever the literature has been published that shows that they are a potential alternative to the conventional shunts and the ONSF. They have a flexibility in adjusting over or under drainage, but it needs further evaluation. We just listened to wonderful talk by Professor Prem, and ONSF versus the LP shunt. Yes, ONSF is a very good entity for taking care of your acute visual loss, and the complications are usually short-lived. Compared to this LP or the BP shunt, it directly addresses the problem of the ICP, but on a chronic way, because that's going to take a longer time. It's a good entity for mild to moderate IIH. It's a cost-effective and easily available. The ONSF is not that easily available at every center. So I can't give you a verdict, but shunt is definitely, it can be offered in intractable headache and visual loss as a predominant symptom with or without edema. There is a local expertise available, and in cases of the shunt failure, you can complement or supplement it with other techniques which we just heard about, the ONSF and the stenting. Apart from it, the other symptomatology like the cognitive deficits are directly related to the ICP, which are better taken care by CSF diversion. We know that with a lumbar puncture, we evaluate these patients with an immediate improvement in their MMSE scores and all that. If you put it and it drains chronically, then your chances of the cognitive performance definitely gets better. And in those cases, I think shunt gets a preference to the other techniques. This is a wonderful, recently published analysis in the Neurosurgical Review about the different surgical treatment options which are being used for the IIH in the literature. And you can see here that the shunt procedures improve the visual functions in nearly 67%, visual acuity in 55%, which is comparable to the other techniques also. It improves the papilledema immediately, but it comes at a high failure rate, that is 43.4%. If you follow these patients for a long term, you realize that you may need to revise down the road. Among other options, though it has a lesser number bariatric surgery, probably you are hitting the basic pathophysiology by doing a bariatric surgery. You improve the visual function, acuity, headache, papilledema, everything, but it still has a severe complications, and that probably needs to be addressed in the long term while managing this disease. So to conclude, it's still the gold standard and it has the historical support. It's effective, but does it really remain effective in the long term? That's an open question. It improves the vision, it stabilizes the vision in most of the patients. It helps in management of the headache in most of the patients, but it cannot be guaranteed to these patients. Probably, we are hearing so many wonderful talks in the morning. Probably we need to develop a predictive model looking at the hormonal profile, phenotype, obesity, genetic factors, all those things, because you are linking it with probably everything from fibromyalgia to CRPS. All these things are linked with IIH in some or the other way. You might look at draining the lymphatic system again, lymphatic again, treatment aimed at improving the quality of life, and we need to seriously take care of the headache for these patients. Thank you so much.